It's a great honor to attend this Science Foundation's first endoscopic course. Thanks for the invitation. Thanks, Christophe, for your kind invitation to give me this wonderful chance to talk about the worldwide state of the endoscopic spine surgery. As Saki mentioned earlier, he's a great talk about the endoscopic benefit zone. We all understand the endoscopic surgery has great potential and the benefit for treating our patient in terms of the degenerative spine as well as infection in the tumors. It promises the quicker recovery time and lesser pain and the fewer complications compared to the traditional open surgeries. Nowadays, we have three kinds of endoscopic surgery. One is microendoscopic surgery, and the others are bipolar and full endoscopic surgeries. Interlaminar approach is mainly done by all three kinds of endoscopic surgery, but the transforaminal approach is a unique approach orientated by the full endoscopic surgeries. Historically, ever since the Campbell's proposed the Campbell's triangle in 1980s, I think the early pioneers period of the endoscopic surgery in 1990s, we met the era of the TESIS and the YES system from the Hoogland and Tony Young's. They have different concept, but aim the same goal to treat this condition through the narrow spinal frame. And then we, the manufacturers, companies like Richard Wolf and Joy Max and Max Moore, they expanded their category, and many Chinese companies were added on. Now we are living and facing the opening of the golden age of the endoscopic surgery these days. The advance of the endoscopic surgery is mainly due to the wide range of the spinal condition can be treated with the endoscopic surgeries. But in addition, that it causes the lesser tissue dissection and the normal structural damages and reduces blood losses and epidural scarring, reduces the hospital stay and early function recoveries. The advancement of the endoscopic instrument is also very important to make our surgery more effective and versatile. And we can perform any complex surgery with great precision and controls. This global emergence of the endoscopic surgery and the adaptation is due to the growing interest in the value-based spine care program, which is significantly rise in adaptation across the globe. So the technical advancement is very important. And also important thing is growing the teaching programs like this course. If you look at these figures from the to see the global trend and hospitals and the endoscopic discectomy, you can see the last 10 years it has a growing popularity, as well as is the numbers of the research, as well as the case of the surgeries, mainly led by the China and South Korea and the US. China has a great powerful potential to publication, and South Korea has a great number of the citations, and the US also has a great number of the citations and the publications. This is more the visually set forward to see to highlight the region representing the adaptation and endoscopic surgeries. You can see the blue and the dark light on the US and the Asians and the Europes. This line is also shows the number of the collaboration between the countries. So through these figures, we can see the high utilization of the growth in Asian European markets. The Asian surgeons are also well known for performing the modern, the minimal invasive endoscopic surgery compared to non-Asian surgeons. And especially the innovation within this field of endoscopic surgery, such as the development of the bipolar endoscopy, largely driven by the Asian scientists and surgeons. So there are many questions why the region difference between the adaptation, the MIS, and endoscopic surgeries. Junseok Kim has a good answer for this. Shortly, the east is changing around the surgeon's hand, and the west is around the technology. That means it's more dependent on the surgeon's skills on the endoscopic surgery. The east culture is meet this philosophy well, but Western country has more driven by the technology and the instrument companies. So if you look at the large number of the scientific society, the teaching or the focus on the endoscopic surgery in Asia, there are lots of numbers of endoscopic society in Asia, particularly in South Korea and Japan and China. I was trying to put all the numbers, but it's too many. I just put on only less than half of them in this figure. The China has a special endoscopic surgery markets, and because they feel the technology gap of minimally invasive surgery in the endoscopic surgery fill the gaps. That means China skipped the error of the microsurgical dissection in spine surgery. They just jumped and straight forward to endoscopic surgery. That based on Chinese philosophy to avoiding open surgery, and also meet the Chinese government philosophy to reduce healthcare cost. South Korea is well known to pioneering the endoscopic surgery. Its early adaptation and the widespread. There are high volume of the procedure every year to perform, and they have a very well-known established training program and the center of excellence. For example, with the hospital work, we performed over 100 endoscopic course privately, and we teach it over almost 900 foreign doctors so far. There are many researches to show the global hospitals and research hospitals current status. You can see many names from the South Korea and the Wood Hospital. Recently, there are growing popularization of the bipolar endoscopy surgeries. It also has been developed and led by the Korean surgeon group and the hospitals. Endoscopic surgery in Europe is positive in terms of the increasing adaptation, and there are growing number of trained surgeons, and especially the great access to the technology because of the many famous endoscopic companies from the German companies. But limited the insurance coverage also negative for this market. What about the US? There are growing and acceptance in the surgery nowadays. There are noteworthy institutions and surgeons sitting in the front, but there are still little number of the trained surgeons. Chris Hofstetter, he recently published a very nice and review article, and he mentioned the negative point of the US market is related to the teaching hospital with high overhead cost often prioritized complex surgeries. The high cost of endoscopy equipment is also a hurdle. The endoscopy surgery does not provide enough financial reward. Sorry for Chris, and need for the more robust clinical evidence to support this. Excuse me, to support adaptations. For example, the insurance companies still consider endoscopy surgery as experimentals. So what is good for the endoscopic surgery in the US is now recently put out for the update coverage recommendations. For example, the primary and recurrent disconation and spinal stenosis is a good indication for the endoscopic surgery. This will be a good promotion to clarify and guidance for physician and insurance companies. The endoscopic surgery group, research group is a great potential. I think they are unique around the world to publish and put forth and positive perspective research group research in the future. What about the Latin America and Middle East? There are still between the number of the surgeons, trained surgeons, the infrastructures, but there are very positive growing number of the interest in the potential in future growth. So the overcoming the challenges implement is the first training, the skill development, and the infrastructures and the cost considerations. According to my research, the unit in the US, 10,000 or 20,000 cost for the endoscopy surgery, compared to the China. So in Beijing is 3 to 7,000. In Germany, 12 to 14,000. South Korea is around 6 to 10,000. When you look at this important paper comparing the open surgery and the endoscopic surgeries, they performed a very nice review for comparing the TAD, IAD, and biportal and the microscopic discectomy to analyze the cost per query. And they conclude that endoscopy surgery is very cost effective in terms of its cost per one quality gained. The average cost for the endoscopic surgery was 26,000 compared to the microscopic surgery as 34,000. When you look at the result from the sports trial, the surgery showed low cost per quality gained compared to the non-surgical interventions. That is 34,000 compared to 70,000. So the result is similar with these two different studies. The microscopic surgery and the open surgeries are similar. So the patient side, there the willingness to pay for one quality gain is around 50,000 and 100,000. So when you're considering this result, the endoscopy surgery is a super cost-effective surgery for patient quality of the life. From this data, to analyze and forecast the spine endoscopy market between the 2026 and the 29, US are expected to dominate the endoscopic surgery markets in the future. And because the size is current 600 million in 2022 will be expected annually growth and 8%, reaching to the 1,100 million in 2029. Europe is also expected to have large growth potentials. For example, the German market will expect to have over the 20% of the annual growth because of the increasing number of the seniors in their society. So our challenges and future the perspective for the endoscopy surgeries, there are continuous growth and adaptations and endoscopy surgery around the world. But we need more the robust clinical evidence to support the adaptation. The collaboration effort and research is very important to teach the next generation and our colleagues. So endoscopy surgery, we need a more collaboration and comprehensive training program than the Center of Excellence in the worldwide. The importance of collaboration is just not the friendship, is also knowledge sharing and between the region to support continuous advance in this field. So in conclusion, endoscopic surgery is a global game changer and revolutionizing patient care with minimal invasive techniques, and technological advance and specialized training program have fueled its rapid adaptations. The future projection for endoscopic surgery includes development of new technology and technique, as well as increased automation and integration into standard practice. Thank you for your attention.
Hey, Junseok, I do have a quick question for you. Have you noticed, since you've been, exposed to so many different endoscopic spine surgeons from all over the globe, have you noticed any difference in technique styles in the current day use of endoscopic techniques from, the US versus Europe versus Asia? Just curious, your thoughts on that.
Thank you. It's a difference between the ethnical, the morphological difference. For example, in the Korea, fortunately, our patient has a huge neural fragment, so we actually do not necessarily the extensive bone work, the foraminoplasty, trans-SAP approach for our patient usually. Even the 5L1 cases with just a small limbing will open the neural foramen enough. But when I attended some live surgery in the Germany, I was surprised that their patient has a very narrow neural foramen. This is also one of the reasons why in Korea we can adopt and expanded endoscopic surgery in early days before the foraminoplasty technique was not established yet.
Hey, Junseok, so nice to see you, even though, it would be fun to have you here too. But, you're such a master in this field, so it's always great to learn from you. One quick question I have for you is, like, in terms of the interlaminar technique in South Korea as well as China, you guys often do awake surgeries, and interlaminar is tough to do that way. So where do you see the interlaminar technique? How does it going to develop for, laminectomies and other procedures in South Korea?
In terms of the laminectomy, we do a general anesthesia. It takes time, and the patient should be tolerated during the 1 hour surgeries. But for the discectomy, we only do the interlaminar discectomy on the 5-1 cases. We rarely do the flabectomy, as you guys have seen the last biosecure lab demo. I just put a needle and split the problem in the bluntly. Just as we do the transforaminal approach, we aim to Campbell's triangle posteriorly directly landing into the shoulder part of the root and land into the Campbell's triangle from posterior to anterior, and then leaving the wire and the gradual dilator, we can just go directly into the disc space. So that's the secret. So in that technique, we can do the auricular anesthesia, local anesthesia, and surgery for the interlaminar discectomy procedures.
Thank you for that. And one final question from me is, in my talk, I mentioned how in South Korea, we're seeing this kind of resurgence and emergence of biportal spine surgery. So I know that a lot of Korean surgeons are really adopting this. What's your opinion on that? And what do you think how that's going to fit into the future of endoscopic spine surgery?
Biportal surgery has a great role to expand the surgeon's adaptation to endoscopic surgery world. In other terms, they just want to settle down on the interlaminar approach and perform their microscopy surgery with the other way. This is good for the early adaptation, but as I mentioned before, the transforaminal approach is a very important and unique approach. It's super tissue preserving surgeries. So everyone who performed the transforaminal approach will understand what I'm talking about. But with the biportal surgery, you cannot do that. So I also do the biportal surgery for the endoscopic fusion and the severe stenosis decompression. This works very well, super nice, even faster than the full endoscopic surgery. But I do my discectomy only with the transforaminal approach. Even 5-1, 99% I do transforaminal approach. That is easy for me. And that requires less operation time. But the biportal guys do not want to learn another technique, transforaminal technique, because they know they are the endoscopic surgeon. And so why I should learn another technique, that's it. So for my recommendation for my junior surgeon, the fellows, I first train them from the transforaminal approach. And then if you want to move to the biportal endoscopy surgery, believe me, you just need only 3 cases of the biportal endoscopic surgery will enough for your learning curve. Otherwise, if you first do the biportal surgery, you will require another 20 or 30 cases learning curve for your transforaminal approach. So in the future, you should learn both the uniportal and the biportal surgery for your clinics. But my recommendation to learn how to learn, the way to learn is first, you should learn uniportal transforaminal approach, then move to the biportal surgery. That will be a good way to reach your the endoscopic, experience.
One more little thing is, where do you see in your practice the indications for biportal? So you said fusion surgeries, right? Fusions, and what other procedures?
I do the multi-level decompression and the severe stenosis with the biportal surgeries. That requires less time. Yeah.
Thank you so much. That was a great talk. Thank you.
Thank you.
Okay, I think we're going to be going to the lab now. So the way the lab works, just so you guys are all aware, everyone should have a little punch card because we're going to be rotating every 10 minutes. That way everyone gets maximal exposure. Just so all the proctors.